All right, we are going to come back together. I know 10 minutes flies when we're having fun. It flies by, just like the cardiac cycle. Flew by. I know, so much fun. We are going to cover our last cardiac physiology piece that we're going to cover. Sorry, I took off my jacket because I was hot. But this is the conduction of the heart. This is what we've been building up to. I think, let me just make sure I've shared. Good, I'm not muted. And we are recording. Okay, awesome. The conduction system of the heart. So this is our last cardiac physiology, and then we're going to get into some pathology. So this would be from item 7 in your study guide, describing the location, function, autonomic regulation, and electrical measurement of the conduction system of the heart. So essentially, how does the heart automatically contract, maintain its pace, and what factors change it? And then how do you understand an EKG? That's what we're going to get into. So when we're talking about the conductive system or the conduction system of the heart, there's several components that we need to know, several different anatomical components. So the SA or sinoatrial node, I'm going to refer to it as the SA node. So our sinus node is located here in the atrium. Our internodal pathways, which are going to come off of the sinus node in the atria. Our AV node or atrioventricular node, I'm going to refer to it as the AV node, located here. Our AV bundle, which occurs right after the AV node. And then our Purkinje fibers, which lead to right and left bundle branches. So we can see here our left and our right bundle branches that flow through the heart and flow through the rest of the ventricles. So this here as a whole, gosh, that was horrible. This here as a whole is our, that was a circle, I swear. So I'm not an artist. But this here as a whole is our conduction system of the heart. So we're going to get into a little bit more about how does this work together. So in general, the flow of electricity in the heart occurs as this process. It's self-excited, so self-excitation of the SA node generates our initial rhythmical impulse. The SA node is the starting of this conduction process. It's going to spread through our internodal pathways into the atria until it reaches the AV node. From there, it's delayed. That impulse is delayed at the AV node and in the AV bundle, where it pauses to allow for synchronous contraction of atria, then ventricles, right? If it wasn't paused there, the atrium and ventricles could contract at the same time, and we wouldn't have atrial systole, okay? So that's why that major pause occurs. After that slight delay, it's ever so slight, we're talking milliseconds, right? The impulse, or fractions of a millisecond, the impulse is then transferred to ventricles via Purkinje fibers and left and right bundle branches, and that part occurs almost synchronously. So once it gets through that AV node and AV bundle, it's synchronous conduction through the rest of the ventricle. So we'll break down step by step. So the SA node or sinoatrial node is just a small flat strip of cardiac muscle cells that have no contractile muscle filaments. So that's a really good exam question, right? What's the one portion of the heart that contains no contractile muscle filaments? Well, that'd be the SA node, right? In our atria. That's fantastic. I've used that question, in fact, in an exam before. It's located superiorly, posterior laterally in the wall of the right atrium. So it's only in the right atrium. It's not in the right and the left, only in the right atrium. And it's below and lateral to the opening of the superior vena cava. So what does that look like? Siri's thinking I'm talking to her. Right here. So we can see vena cava, superior vena cava. SA node is located right next to that opening where the blood is flowing through. It's located right on top. The internodal pathways conduct the signal through the rest of the atrium. It contracts or contacts with atrial muscle fibers directly. So although the SA node itself doesn't have any contractile muscle fibers, it does contact atrial muscle fibers directly, which allows for that transmission of the action potential. And it's going to control the beat rate of our entire heart. So again, if you're asked, what is the pacemaker of the heart? It's the SA node. What controls the beat of the heart? SA node. SA node in a normal physiological heart, working normally, is going to control the beat of the heart. Now, it sometimes doesn't, right? When we have arrhythmias or when we have a conduction blockage, the SA node might not control the heart. After an infarction, But in a normal healthy heart, which is physiology, normal healthy, SA node is our pacemaker. So how do the action potentials compare? So when we're thinking about action potentials, we're thinking about what's the difference between the action potential of an SA node, the self-excitatory action potential of the conduction system, and the action potential of a ventricular muscle fiber, right, that we talked about. So we see here, here's our action potential that we learned initially. We have our ventricular muscle fiber. We have our huge depolarization, our minor repol, our plateau, and then our major repolarization. That's our ventricular muscle fiber action potential. Our sinus nodal fiber, we see that the action potential looks much more like a muscle cell, much more like skeletal muscle. It's going to increase and decrease. It's going to depolarize and repolarize, but there's kind of this long, weird waiting period prior to it doing its initial depolarization. And this waiting period here, and the fact that this is occurring at much less negativity than a ventricular action potential is what makes this able to self-excite, which we're going to talk about why it's able to do that. So SA node fibers have a less negative resting membrane potential than a ventricular muscle fiber, okay? This is caused by leaky sodium and calcium ions. What do I mean by leaky? It means that they're able to have funny channels that allow sodium and calcium to leak in and out of the membrane, versus our normal ventricular muscle fibers or atrial muscle fibers don't have those leaky channels, okay? Fast sodium channels, therefore, are blocked from opening because the resting membrane potential is too high. So our fast sodium channels, we remember, open at resting membrane potential and allow for that phase 0 huge depolarization, right? That's what happens in our normal contraction. In our conduction pathway, because we're starting at much higher, much more positive, still negative, but much more positive resting membrane potential, fast sodium channels do not open, causing that huge depolarization. Okay, so that's a big key difference between the self-excitatory process of an SA node and the action potential of our cardiac muscle fibers. This leads to a slower action potential overall. This is why we have this delay period here, because we have to self-excite. The membrane has to reach this threshold here to do its own depolarization and repolarization, okay? So it has to get from, how do we get from here to here? That's self-excitation. So what does that process look like? So self-excitation is the process of automatic rhythmical discharge and contraction. It's what makes the SA node. So at high concentration of sodium in the extracellular fluid, which we know sodium concentration is higher in the extracellular fluid than intracellularly, that's going to encourage sodium to leak inside the cell through an inward funny channel. It's literally called a funny channel. I'm not making it up. I put it in air quotes because that's what it is. It's a funny channel. It has a fancy name, but we call it a funny channel. But it's going to go down its concentration membrane. Its concentration gradient. It's going to diffuse in passively because there's more sodium outside the cell than inside the cell. So we have sodium passing into the cell from the outside to the in because there's more sodium outside the cell at baseline than inside. Between heartbeats, the influx of sodium ions leads to a slow rise in resting membrane potential. We're not having this fast influx. We're not having a fast sodium channel open and pushing a bunch of sodium in. It's just slowly leaking down its concentration gradient. Once that resting membrane potential reaches about negative 40 millivolts, starts about negative 60. So once it increases by 20 millivolts, it's charged. That's going to then trigger L-type calcium channels to open, which triggers the action potential. So we have to get from negative 60 to 20 or to negative 40. So we have to increase by about 20 millivolts. The slow kind of funny influx of sodium does that. Once we hit that negative 40, then our L-type calcium channels can open. We have a huge influx of positivity, which causes that normal depolarization that we're used to seeing. But that's the key. So the final word, what is self-excitation? Leakiness of sodium and calcium causes self-excitation. I say leakiness of calcium because you still have those calcium channels that are open and leaking in that +2 charge of calcium, just like you would see in muscle fibers. So that's underlying, that's baseline, but that's slow. Remember, that wasn't fast ever. That was always slow. So the difference is you have a leakiness of sodium this time, going down its concentration gradient, slowly raising that resting membrane potential. It reaches the threshold, L-type calcium channels open, and boom, we have our action potential generated. Fast depolarization. This action potential is then what triggers our muscle action potential to occur. So we have our conduction action potential, triggers our muscle action potential because they're actually contacted, right? SA node touches the muscle fibers, physical contact, intercalated discs, gap junctions. It's all coming together now. So once we have this action potential here, the AV node, it's going to get sent here from sinus node, gets sent instantly through the internodal pathways. So we have an instant action potential that occurs from our conduction system and then is generated all through the atria and provides a simultaneous contraction of our atria. That contraction is atrial systole that occurs right before what? Yeah, absolutely, absolutely. It's going to occur. Atrial systole is going to occur right at the end of diastole, right before systole, which the beginning of systole is isovolemic contraction. Absolutely. So that atrial systole that happens pushes that blood flow into the ventricle. And we're able to do this because of the AV node delaying our conduction signal, our self-excitatory signal. So when we get to the AV node and AV bundle, their whole purpose is to delay that conduction from the atria to the ventricle. It allows a contraction and then a contraction. The AV node, therefore, is located at the posterior wall of the right atrium, kind of right behind the tricuspid valve. So it's located almost centrally. I don't know if I can change my color. I think I can. Aha, getting smarter. Like almost centrally to the heart, right between the atria and the ventricle. And it occurs kind of right along this line. And you can think about there's like an invisible line separating the atria and the ventricle. It's very large now, invisible line. Why does this occur? Like I said, allowing time for the atria to empty blood into the ventricles prior to contraction. If they occurred at the same time, blood would go every which way, right? If the heart contracted at the same time, it allows for atrial contraction to occur. How does this occur? How does this delay happen? Biochemically or physiologically or microscopically, however you want to say it, there are less gap junctions between cells in the AV node and bundle. So if there's less gap junctions, there can be less what? What do gap junctions allow for free flowing between cells? Ions, right? So if there's less gap junctions, there's less communication of ions. So it takes longer for that ion signal, that depolarization, that self-excitatory process to occur in the AV node. So it's a delay. It takes a little bit longer. And I'm talking 0.4, 0.5 milliseconds. Can y'all hear me online? I think I unmuted. I did. Okay, good. Go team. So it slows that transmission of action potentials due to slower ion permeability. Okay, simple as that. Less gap junctions, slower signal. So once we do get through the AV node and the AV bundle, we then pass that signal down to our Purkinje fibers and our left and right bundle branches, which rapidly transmit the signal to the ventricles. Purkinje, you can think of the Purkinje fibers as the opposite of everything the AV fibers are. They're larger even than ventricular muscle fibers. So these are big fibers. They transmit the action potential even faster than muscle fibers do. And they're located beneath the endocardium and they spread over the whole ventricle, eventually becoming continuous with muscle fibers. You could think about them as a whole web. They kind of engulf the whole ventricle. And so once the signal gets through the AV node and AV bundle, it's going to simultaneously contact all components of the ventricle pretty much at the same time, which then leads to a synchronous ventricular contraction. If they didn't do this, you would have part of the ventricle contract before the other part of the ventricle. And that would not be an effective muscle or pumping system. How does this occur? They have a higher permeability of gap junctions at their intercalated discs between cells. So AV nodes, AV bundle, less gap junctions, less permeable. Purkinje fibers and left and right bundle branches, they have a higher amount of gap junctions, a higher amount of permeability. So, and the fibers are bigger. So they're going to spread the signal much faster. This process itself is a one-way conduction pathway. The signal is unable to travel backwards from the ventricles to the atria. This prevents re-entry of a cardiac impulse in a normal state, right? There's many states where we can have re-entry, AFib, We can think about all kinds of sorts of bundle branch blocks and all sorts of funny arrhythmias we can see on EKG that can be a part of this process not going so well. But in normal physiology, it's a one-way road, one-way pathway. The signal is forced from the SA to AV to Purkinje fibers because the atria and the ventricles are separated by this insulating fibrous barrier. The only place where that fibrous barrier doesn't occur is at the AV node and AV bundle. Pretty incredible. So you can think about, we're sending an electrical signal. An electrical signal can transmit through down a pathway until it meets kind of like a fibrous, insulator. The heart has this fibrous insulator separating every component from atria to ventricle except for at that AV node and AV bundle. So that's how the signal is able to get through. This is that control piece of the conduction pathway. And I personally think it's pretty dang cool. The pace of the heart is set by the SA node. So again, the SA nodes are pacemaker in a normal state, sets the heartbeat at a pace of 78 to 80 beats per minute. Obviously, this can speed up or slow down depending on other factors, right? Our autonomic nervous system, different ion concentrations, intrinsic contractility of the heart. But the SA node is setting the base pace of the heart when we have no other inputs. This discharge rate of the SA node is faster than its baseline self-excitatory discharge of the AV node or Purkinje fibers. That's why the SA node is the pacemaker, because the SA node beats at about 70 to 80 beats a minute. That's how long it takes for the self-excitatory process to go. For the AV node, it goes about 40 to 60 beats a minute, and the Purkinje fibers are about 15 to 40 beats a minute. So by the time the SA node is sending out an impulse, the AV node hasn't quite even gotten their baseline membrane to reach that point where they're able to generate an action potential. But once that impulse comes through, then bam, they have that action potential. So it gets overtaken by the SA node. That means, though, if the SA node breaks down, the AV node is going to take over. And your heart rate's going to be at 40 to 60 beats per minute. If the SA and the AV node break down, there's a blockage of both. Let's say you have an infarction that blocks that conduction pathway. Then Purkinje fibers are going to be at 15 to 40 beats per minute, which is really not compatible with life, which is why you get a pacemaker put in, which then does the pacemaking for your SA node for you, sends a signal to the heart for your SA node, taking over that process. Any place where a pacemaker is located that's not the SA node, on the internodal pathways, Purkinje fiber, anywhere, it's called an ectopic pacemaker. It's not at the SA node, it's an ectopic pacemaker. Okay. So again, our autonomic nervous system is going to be the main system that exerts control over heart rhythmicity and impulse conduction via cardiac nerves. How does that happen? We'll talk a little bit about how the autonomic nervous system controls the conduction process of the heart. So parasympathetic, I know it's on the side. Parasympathetic stimulation, our vagal nerve, our vagus nerve stimulates, can occur mainly at the SA and AV nodes. It's only minimally innervated to the atrial and ventricular muscle. Stimulation of our parasympathetic pathways is going to release acetylcholine at vagal nerve endings, is bringing back your neurotransmitters. We'll talk again about this in our neurology section. But acetylcholine is going to increase your permeability of your membrane to potassium, increasing your membrane negativity. It's going to hyperpolarize your membrane, making it more negative. If your membrane's more negative, it's less excitable, right? The more negative our membrane is, the harder those pacemakers have to work to get it up to that level where it's able to self-excite. So the more potassium we are able to permeate, going to increase your membrane negativity, make it less excitable. The outcomes is going to be a decreased rate of rhythm of the SA node, so decreased heart rate. Also going to have a decreased excitability of your AV junctional fibers between your atrial muscle and your AV node. So slower transmission of your atria to your ventricular signal. And overall, the outcome, slower heart rate. Heart rate slows down. End of the day. So big takeaways here, parasympathetic stimulation, vagus nerve, mainly going to happen in your atria, your SA and AV nodes, going to stimulate acetylcholine release, going to increase potassium membrane permeability, going to make your resting membrane more negative, less excitable, slower heart rate. Okay. Now on the opposite side, sympathetic stimulation. So sympathetic nerves are distributed to all parts of the heart. Again, remember, sympathetic stimulation can increase the contractive force, the strength of the heart muscle. So sympathetic nerves have contact points across the whole heart. Strong showing in the ventricular muscle. Norepinephrine is released at nerve endings. It's going to stimulate those beta-1 adrenergic receptors. Ooh, this is fun. We'll talk about these. I'll make a little pathway for you later. But stimulates those beta-1 adrenergic receptors, norepinephrine. Stimulation is going to increase cardiac rhythmicity and increase cardiac conduction. You're going to have a higher rate of SA node discharge. You're going to increase the rate of conduction, the level of excitability throughout the heart, and the increased force of contraction to all musculature. So essentially, the baseline is going to be the opposite of the parasympathetic system because of norepinephrine stimulating beta-1 adrenergic receptors. Now, on a fibrous level, on a microscopic level, the mechanism of action is actually still somewhat unclear. They say potentially they increase the membrane permeability to calcium, more positive resting, and sodium, more positive resting potential, easier self-excitation, but they say potentially. So anything that you read in a book that says potentially, you don't need to memorize for the NPLEX because they're not going to put a potential on your exam. NPLEX also information is about 2 to 3 years old. So anything that's come out in a study in the past year or two, not going to be on your exam. So keep that in mind. That comes in handy a little bit more when it comes to NPLEX 2, when it comes to treatments. Berberine had just come out like on the game as a treatment for diabetes and hyperlipidemia when I was graduating. I know, agent. But it was exciting, and that was not on the exam because the studies had just come out, and so they weren't going to have anything included about something that was just brand new on our test. So I was all excited. I was like, oh, I know that. And they're like, no, it's not going to be on there. They don't know that yet. They know it, but it's not written in the exam yet. So realize that. It's a couple years old. COVID might be on the exam now. I feel like it's been 2 to 3 years, right? COVID could maybe make an appearance on your exam, but I don't even think it's on your study guide, so it probably won't be there. But anyways, opposite effects. Sympathetic stimulation increases heart force, increases heart rate. So how do we measure conduction? EKGs. Oh, love EKGs. They're so fun. Okay, conduction activity. So I gave you a handout. I encourage you to use the handout. You print it. It has EKG paper on it. Practice drawing your EKGs. But you probably will not have to actually interpret. Actually, I can guarantee you won't have to interpret an EKG on the exam. But you will need to understand what the different parts of an EKG mean. All right? This exam is not to test your diagnostician skills because they don't expect you to be a diagnostician yet. It's to test your ability to understand the physiology and the pathology behind these different conditions. Okay? So our waves of the EKG, we've already talked about this a little bit. So it'll be somewhat review. So I'm going to pop these up here. So again, our P wave occurring right here, beginning of atrial contraction, represents our depolarization of the atria. QRX complex, depolarization of the ventricles, beginning of ventricular contraction. T wave, ventricles remain contracted until the end of the T wave. T wave represents repolarization of ventricles. After the T wave is when we have that isovolumetric relaxation, right? And we talked about this last time, but your atrial repolarization is obscured in the QRS complex and typically not visible on EKG. So some intervals that will be important to just understand. Your R to R interval is referring to the top of a QRS complex to the top of the next QRX complex. This is the rate of one single cardiac cycle or heartbeat. It can be used to calculate a heart rate if consistent, right? If it's a consistent beating heart, it's regular, not irregular. You could use an R to R interval to calculate a heart rate. The P to Q or P to R interval from the beginning of your P wave to the beginning of the QRS complex represents your depolarization of the atria to the beginning of ventricular contraction. I do have normalizations like the times 0.16, but I doubt you'll need to know that for exam. It's really on there for reference. And then the QT interval represents your depolarization and repolarization of the ventricles. So again, your Q to the end of your T right here. up top, QT. Your Q to the end of your T interval. And again, I have normals, but most of the time with EKG questions on this exam, they're wanting to know if you can tell the relationship between repolarization and depolarization and of what. So if you have that down, you'll be fine for EKG interpretation. When reading an EKG, again, reference, I doubt you'll need to know this, but if you do, I'm gonna put it on here anyways, so you have it. The horizontal calibration lines, 10 small lines equal 1 millivolt. It's positive if it's upwards and it's negative if it's downwards. So this is positive millivolts up here, negative millivolts down here. So negative, positive, okay? Vertical calibration lines, 1 big box, so this would represent a big box here, is 0.2 seconds, and 1 small box, this itty bitty little dude right here, is 0.04 seconds. And if you ever need to calculate the heart rate from the EKG, you can take the reciprocal of the time interval between an R to R interval. Again, I've never seen a math calculation on N+1. I've only taken it once, but I've never heard over my years of a math calculation on N+1. But if you had to take it, you could calculate a heart rate that way. And that's it. You know all of heart physiology. What do you know? You feel smarter, you should feel smarter. Okay. Those are the big highlight, big pieces of the puzzle. We're gonna move into path. Just take a minute and like power pose, whatever you can do. I don't know who power poses before exams still. Do any of you power pose? Have you heard of power posing? Yes, no, maybe so? Maybe? I power pose between every NPLEX exam, every big exam of my life, let's be real. I did like a arms up above, or like a hands on my hips, like I'm Superwoman or Wonder Woman or whoever does that. Or like the cross, like, I don't care, I got this. If you're sitting down, my favorite power pose is this one, the like feet on the table, like totally like, oh yeah. I didn't do that one on the NPLEX, that would probably be a faux pas. But I encourage you, power pose, stretch, do whatever you gotta do. I think there is some studied evidence to it. I don't really know what the mechanism is, but it makes me feel good. So maybe that's what it is. All right. We're gonna move into some pathology. We're gonna get through one of these and we'll take a break. And then we'll see how much we can power through before the end of the day. I always pack in more than I actually have time for. But I wanna get through some path, some cardiac path. This is gonna get through a lot of the major cardiac pathologies, the next like 6-ish, 15-minute or 15 sliders. And all of them are gonna have a similar feel to them. They're all gonna contain these following 6 sections, which is what NPLEX wants you to know about each of these diseases. A definition, so can you define it in like a simple sentence? Risk factors for the condition, etiology or cause, complications or outcomes, pathogenesis, so how does the disease develop within the body? Where does the physiology go wrong, right? And clinical characteristics, symptoms, pathognomonic signs, right? Those are gonna be your big pieces of the puzzle. So I encourage you, and I'm gonna post, I hadn't quite posted this yet, but I'll post a quick, like easy study sheet that you could use as a guide. But as you're going through all these path pieces, I encourage you to fill out like 1 sentence or 1 highlighted line in each of those 6 sections per pathologic condition. Just 1 line, 1 sentence. So you're not gonna include every single thing, but you're gonna wanna include the thing that seems the most important to you, or maybe the thing in your brain that just isn't sticking in, and that's what you're gonna wanna study, okay? Sometimes there's gonna be a pathognomonic sign where you're like, oh, I gotta remember that. Sometimes maybe it's gonna be a specific risk factor that's weird. You're like, oh, that's odd, I need to remember that one. But I encourage you to keep it simple. Don't list every single thing that's on these slides in your study material, because you won't need to remember it. Some of it is pretty obvious, right? Tobacco use, probably gonna be a risk factor for a lot of heart disease, right? Sedentary lifestyle, probably gonna be a risk factor, okay? So keep those things in mind. You don't need to write those things down. All right, so we're gonna start with hypertensive heart diseases. This is 18.1, systemic and pulmonary hypertension. This is gonna be pretty straightforward, so I'm gonna go through it relatively fast. Your definition is going to be a persistent systolic blood pressure of greater than 130 or diastolic greater than 80. Primary is multifactorial, and secondary is due to other causes. Think kidney, okay? When in doubt with secondary hypertension, majority of the causes outside of hyperaldosteronism is kidney-based causes. Polycystic kidney disease, chronic kidney disease. So when in doubt for secondary hypertension, choose a kidney option if you have a kidney option given. Risk factors, your classics. Okay, I don't think there's anything on here that's shocking. Obesity is included. I don't love it, but you could be tested on it. So this is one of those things where they are not a health at any size test, right? They have, I believe, removed some of their risk factors that are less appropriate, but you will see gender potentially as a risk factor included in a vignette, and size or lifestyle factors. So I do want to warn you with that. Complications, your classics: coronary artery disease, left ventricular hypertrophy. Now that you should shock you. I think CKD is an interesting one, chronic kidney disease from hypertensive nephropathy. So think about, where there's small vasculature that can affect an organ. So kidneys, extremities, eyes, heart, right? High pressure systems and small little vessels, not going to be a good outcome. Your pathogenesis, this is multifactorial. So that means that it's not a really great test question because there's lots of options, right? There's some genetics. There's sympathetic nervous system activation. There's renin, angiotensin, aldosterone system problems. There's lifestyle risk factors. When you think about it with blood pressure equals cardiac output times total peripheral resistance, TPR. So things that could increase cardiac output could increase blood pressure. So increased heart rate, increased contractility, so exercise, anxiety, and stress, increased preload, so the amount of blood filling the heart, and decreased afterload. All these things can increase cardiac output. Anything where cardiac output is increased could increase blood pressure. Same with total peripheral resistance. If your blood vessels are clamped down and vasoconstricted, it's going to increase peripheral resistance. You're going to have to work harder to pump blood through those tiny vessels. That can also increase blood pressure. So the amount of blood circulating and the diameter of your blood vessels. So I like to think about it that way. What can increase cardiac output? What can increase my total peripheral resistance? Any of those things could be risk factors and contribute to the pathogenesis of this condition, right? You don't have to memorize 5,000 things then. You just have to know logically what could do those processes, what could increase those two processes. We're not going to talk a ton about renin, angiotensin, aldosterone yet. We will when we get to the kidneys. Don't you worry, we're not leaving this yet completely. We will make sure we do a review, but this is a key component of hypertension, so it will come back when we talk about kidney systems. Signs and symptoms or etiology, like I said, etiology, multifactorial, so not one great cause, unless if it's secondary, right? Then think kidney. So primary, not multiple factors. Clinical characteristics, most commonly asymptomatic, not super helpful, blood pressure increased. Could see complications and signs of end organ damage. Probably the best sign or symptom they might give you is on a fundoscopic exam, you see hypertensive retinopathy, right? Or papilloma, some type of change in those blood vessels in the eyes, microvascular changes, but likely not. With blood pressure, they're probably going to ask you about things that could increase cardiac output or total peripheral resistance, or they're going to ask you about that renin, angiotensin, aldosterone system. Or it's going to be a risk factor for something else, most likely. All right, so pulmonary hypertension. I want you to forget everything you know about hypertension now because we're doing pulmonary hypertension. It's different. So pulmonary hypertension, increased pressure in the pulmonary vasculature, just pulmonary vasculature. So think about those pulmonary veins, arteries. That's where we're talking here, pulmonary hypertension. Your mean pulmonary artery pressure is going to be elevated, greater than 20 millimeters of mercury at rest. That's the definition. Risk factors are also many. It depends on the etiology, and there's 4 kind of major etiologies that we'll look at. So I listed some here, but obviously think about things in the lungs. That's going to be probably your best bet when you're thinking about risk factors. Anything also that's systemic that can cause fibrosis So connective tissue disorders, scleroderma, things that can increase lung fibrosis long-term, that could increase pulmonary vascular pressure. Also heart failure, okay? So things that heart failure, right-sided heart failure, congestive heart failure, things, MIs, things that can damage the heart, make it harder for the heart to pump through to that pulmonary vasculature. Complications, arteriosclerosis. We'll talk about what that means, difference from atherosclerosis. There is a difference. Hardening of arteries, right? Medial hypertrophy, so increased in that heart, that middle part of the heart, increased in that diameter. Intimal fibrosis of pulmonary arteries. So again, fibrosis, so less compliance of those arteries. That's why they get hypertension, because they can't actually dilate or constrict as well. They're fibrosed. These are all complications of pulmonary hypertension. I love MedComics. This is the website I got this picture from. You can actually subscribe and get, if you're like into the comic things. PicMonic is also another one. But they can be helpful in kind of describing pathogenesis or different kind of pulmonary or different conditions. But your pathogenesis here, you're going to have essentially a couple things. Increased pulmonary vascular resistance, so the vessels are less compliant. It's going to lead to increased right ventricular pressure. It's going to lead to increased right ventricular hypertrophy. It's more pressure, the muscle's going to get stronger and bigger and thicker, which then can lead to right-sided heart failure. So if you ask me what's a major cause of right-sided heart failure, pulmonary hypertension would be pretty high in mind. Number one cause of right-sided heart failure is left-sided heart failure, but this one will be pretty high up there in my list. Microscopically, in primary pulmonary hypertension, so in someone who has a primary lesion, meaning that this is more likely a genetic or a embryonic condition that's leading to this, a mutation, you can see smooth muscle proliferation that occurs due to decreased apoptosis from a genetic mutation. That's the BMPR2 gene, which that's not French, that's bone, morphogenetic protein mutation. Essentially what that mutation does is it increases smooth muscle proliferation. So smooth muscle cells increase in amount because they don't die, they don't apoptose. So you have increased smooth muscle cell proliferation around those vessels. You're going to have less compliance, right? They're going to be less likely to be able to vasodilate because you have more smooth muscle surrounding them, keeping them stuck in place. This is a genetic component of pulmonary hypertension. This does have the 4 different groups, like I mentioned. So group 1, pulmonary arterial hypertension. This is probably what we think about the most. Number 2, this is actually the most common, sorry. Number 1, pulmonary arterial hypertension. This is most of the time idiopathic, drug or toxin induced, or connective tissue disease. Group number 2 is the most common due to left-sided heart disease. Group number 3, due to some type of lung disease or hypoxemia, so that's where tobacco use can come into play. Or group 4, due to chronic thromboembolism, so some type of pulmonary embolism or chronic thromboembolism, some hypercoagulable state. That's where anemia and things like that can come in. They have group 5, it's just unclear, so that's not helpful. Group 5 is unclear. So yes, there are some reasons that happen, we don't know why. So here again, if that picture confused you, these are your 5 groups. Again, idiopathic or miscellaneous, I kind of don't count. So it's really 4 groups with the idiopathic of we don't know. Pulmonary arterial hypertension, pulmonary hypertension with left-sided heart failure, lung disease or hypoxemia, or due to chronic thrombotic or embolotic disease, some type of embolism, chronic embolism, hypercoagulable state. Your clinical characteristics make sense. You expect if your lung vesicles, your lung vasculature is less compliant, you're going to have things like trouble breathing, maybe passing out, tiredness, edema, palpitations, chest pain on exertion. It looks very similar to CHF sometimes in symptoms, congestive heart failure. One important lesion you may need to know is plexiform lesions. This would be a pathognomonic for pulmonary hypertension. These are complex vascular formations that originate from remodeled pulmonary arteries. So think about it as like a spider vein in your lungs, right? So you're going to have some vascular remodeling because these vessels are becoming less compliant. When you see that under microscopy, you're going to see what is called a plexiform lesion. So if you see plexiform lesions are present on biopsy or present on autopsy, or plexiform lesions are present, or if they're saying that your patient has pulmonary hypertension, what might you see on microscopic exam? Plexiform lesions, pulmonary hypertension, plexiform lesions. You can also see medial hypertrophy. Again, that right-sided heart muscle, right-sided ventricle is probably going to get hypertrophed, going to be enlarged, going to have to work harder to pump blood into the lungs. Okay. Now a little bit on moving into, this moves perfectly into congestive heart failure. We just talked about how pulmonary hypertension looks like congestive heart failure. We're going to get through this, and then we'll take a break. You have right-sided and left-sided congestive heart failure. But heart failure itself is essentially cardiac pump dysfunction. It's going to lead to congestion of your heart, decreased cardiac output, and low perfusion. So more blood in the heart, your body's able to pump it out less effectively, so more blood hangs around, right? Your end systolic volume is going to increase because you're pumping it out less effectively because the heart is having a harder time. And since you're pumping out blood less effectively, you're going to have less perfusion to your tissues. So your heart's going to try to pump harder and try to pump harder. Then you can get hypertrophy and all sorts of other complications, which we'll get to. So two types of left-sided heart failure, systolic or diastolic. Systolic is heart failure with reduced ejection fraction, often referred to as HFrEF. You're going to see increased end diastolic volume, like I talked about, and decreased contractility. Your heart's not able to pump as effectively. Diastolic dysfunction, heart failure with preserved, so PEF, ejection fraction. You have normal end diastolic volume and decreased compliance. So your heart is not able to deal with changes in filling as well. Decreased compliance. Increased end diastolic pressure then occurs. It's able to stretch less. So risk factors here, I would say these are all pretty, make sense. Valvular heart disease being an interesting one. Hypervolemic states, any condition that can cause more blood volume. Clinical characteristics, keynote here would be the S3 heart sound. So you're going to hear an S3 heart sound. Ba-dum-bum, ba-dum-bum, ba-dum-bum. Third heart sound. JVD, jugular venous distension, and pitting edema can occur. And so what's the difference, though, between right and left? Right-sided heart failure, definition here, cor pulmonale is isolated right CHF due to pulmonary etiology. So if you have a pulmonary cause of right-sided CHF, it's called cor pulmonale. So if you see that on exam, that's what they're referring to. You can assume then it's a pulmonary cause. Or if they say, or if they ask you, your patient has congestive heart failure due to COPD and no other heart condition, which would be rare. But let's say they do. What is this called? Cor pulmonale would be your answer. But the most common etiology of right-sided heart failure is by far left-sided heart failure. So if you're given a right-sided heart failure question, when in doubt, pick left-sided heart failure as your etiology. Or what's your most common complication of left-sided heart failure? Probably right-sided heart failure, right? Left is going to cause right. Right-sided CHF, again, some pathogenesis of the clinical characteristics of right-sided heart failure. You can have things that cause more blood flow backup. Okay, so you have blood coming into the heart, your right side of the heart's having a harder time pumping blood from the system through the lungs into the left side. So you're going to get a backup. So things that get congested is your liver, you're going to have your jugular vein, and you're going to have peripheral edema. All congested, right? Everything's swollen and puffy. Congestive hepatomegaly, that can decrease your liver flow, portal flow. And on cadaver exam, you can get something called a nutmeg liver. So if you're looking for a pathognomonic for right-sided congestive heart failure, a nutmeg liver, it's essentially a modeled appearance of a liver on a cadaver exam, would not be helpful for diagnosis. JVD, increased venous pressure, often seen as pulsation of your jugular vein, and peripheral edema. So left-sided heart failure, most of the time your etiology is things that cause ischemia. So ischemic heart disease, hypertension, valve disease with the left side of the heart, or any myocardial disease in general. Heart attacks can lead to left-sided CHF. Complications, by far the most common, is AFib. Second probably would be thrombosis and stroke. Of course, right-sided heart failure is also a common complication. You can have hypoxic encephalopathy, so congestion of your liver and brain leading to coma and death, so obviously down the road. But by far most common, I would say AFib, when in doubt. That's why I would choose as a complication. Atrial fibrillation, random contraction of the atria. Some symptoms and why they occur: orthopnea, shortness of breath when lying flat; paroxysmal nocturnal dyspnea, breathlessness awaking from sleep, almost like a sleep apnea event; and pulmonary edema. So orthopnea, you can just think of all of these things as vascular congestion. You're having a hard time pumping blood through effectively, and so it's essentially pooling in areas you don't want it to pool, specifically the lungs, right? You're having a hard time pumping blood out into circulation. Where is it going to pool? It's going to pool in your lungs, and it's going to pool on the right side of your heart. So someone often who has a CHF exacerbation almost sounds gurgly on exam. They gurgle when you listen to their lungs. Really cool, not for the patient. Really cool for you, first time you hear it. Not great for the patient. Your pathognomonic for left-sided heart failure would be HF cells, heart failure cells, and lungs. This is hemosiderin-laden macrophage. So macrophages that are hemosiderin-laden, they're called heart failure cells. So if asked what immunologic cell could be present on exam or on microscopic exam of a patient with left-sided CHF, HF cells, heart failure cells. That's it. You now know hypertension, pulmonary hypertension, right and left-sided congestive heart failure. Okay? Do we want to break or do you want to keep going? We're at a break time. If you want to break, speak now or forever hold your breaks. Okay, raise your hand if you want to break. Okay, great. Raise your hand if you don't want to break. Okay, that wasn't helpful. That was about even. How would we do a 5-minute break, a fast break? Stand, stretch, then we come back in. So those of you that need a break, go take one. Those of you that don't, stay here, and we'll populate our necks.